Hello everyone, my name is Tatiana. This is a general epidemiology class with Dr. Schumacher, and I will be presenting on 2007 Acanthamoeba keratitis outbreak. So let's begin our investigation. So let's take a look what happened back in 2006. So May 2006, Illinois Department of Public Health expressing some concerns. Ophthalmologists around Chicago area have reported more than usual cases of Acanthamoeba keratitis, also known as AK. The most frequently reported symptoms among patients were pain, redness, sensitivity to light, and sensation of foreign body, in addition to blurred vision, discharge from eye, and increased tearing. So the Department of Health is asking help from CDC, and CDC is wondering if AK cases increase only happening in Illinois or other states involved as well. Investigation began and case patients were enrolled during March 2006 to July 10, 2007. Initially, 221 AK patients identified from 37 states of Puerto Rico, and 158 had infection that met the case definition. 105 cases were officially reported among 30 states. So amoeba is ubiquitous, free-living organism that is found commonly in the environment, including water, such as tap water, recreational water. It's also found in soil, sewage system, cooling towers, and heating, ventilation, air conditioning systems. In contrast to many other protozoa that cause disease in humans, amoeba usually feeds on bacteria, fungi, and other protozoa, including cyanobacteria. And it is found in greatest numbers in mostly water environment. And now we're all wondering how amoeba gets in the eye. So Acanthamoeba primarily affects otherwise healthy persons who wear contact lenses. An estimated 85% of US cases occur in contact lens wearers. Persons who improperly store, handle, or disinfect their lenses, for example, using a tap water or homemade solution for cleaning. People who swim, use hot tubs, or shower while wearing lenses. Persons who come in contact with contaminated water have minor damage to their corneas or have previous corneal trauma, increased risk of infection. So what is interesting, the Acanthamoeba expresses the MBP is a transmembrane protein with characteristic of a typical cell surface receptor, which mediates the adhesion of amoeba to the surface of the cornea. After the MBP-mediated adhesion to the host cell, the amoeba produce a contact-dependent metalloproteinase and several contact-independent serine proteinases. So these proteinases work in concert to produce a potent cytopathic effect, which is means cell destruction involving killing of the host cell, degradation of the epithelial basement membrane, and underlying stromal matrix, and penetration into deeper layers of the cornea, which leading to corneal destruction and finally blindness. Let's refer to image 2. Well, you can see how microscopically amoeba looks in the tissue, and here the green arrow pointing into amoeba. So let's go back to our investigation. We have a question. So what most patients have in common? We started our investigation with 105 cases. Investigation continued during June 14 to July 10, and more than 11,000 phone calls were made to obtain 148 controls that were matched with 91 case patients. Case patients with non-matched controls were excluded from subsequent analysis. Case control study was conducted. So from figure 1, we can see the most patients were users of soft contact lenses, which is 72 patients. And further investigation showed that case patients had a 16.9 times the odds of reporting a use of MAOCMP, which is Advanced Medical Optics Complete Moisture Plus lens solution compared with controls, and it falls into a 95% of confident interval, which is statistically significant. I would like briefly discuss these two figures that were used during investigation. So the figure 2 shows spread of cases around the states. What I have noticed that most of the cases were reported in California. And when I was reading that AMOCP solution was introduced in sale in 2003, and it was manufactured in California just before the nationwide increase in cases. And it kind of makes sense why most of the cases were in California, although the first reported cases were in Illinois, Chicago area. But I think since it was manufactured in California, it was probably available in more stores to buy this solution. And on figure 3, we can see that majority of the cases, reported cases, were from 2006 to 2007, which is a year before the investigation. So we can only speculate how many cases were unreported since solution was already on the market since 2003. To confirm that AMOCMP solution is the reason of the outbreak, laboratory investigation was performed. Initially, we received 94 specimens from case patients. So they included 10 culture isolates, 4 corneal specimens, and 80 environmental specimens, which are 48 lenses or cases, 32 bottles of the solution that included 5 unopened bottles. So investigation concluded that AMOCMP is the reason for increased cases of Acanthamoeba keratitis. So investigators suspected that AMOCMP was insufficiently against Acanthamoeba. What does it mean that this solution is insufficiently active against Acanthamoeba? So this product is different from AMO Complete, the multipurpose solution that was manufactured before. So why AMOCMP is different? So it had a new ingredients such as propylene glycol and taurine. So after this outbreak, laboratory investigators found that propylene glycol may cause Acanthamoeba trophozoite 2 and site, thereby making them resistant to disinfection. Investigators look for more data on other solutions that are used for contacts. Unfortunately, there were little data available on testing of other solutions on the market, so it's really hard to make a comparison. But there was another ongoing case control study that was conducted in the Chicago area, which investigated 55 separate cases, and they also found that AMOCMP is to the most important risk to ongoing Acanthamoeba keratitis outbreak. So let's look at another hypothesis that were proposed during this outbreak. So municipal water to blame. So Acanthamoeba organisms are present in the water of many households, and temporal association was noted between an increase in AK cases in the Chicago area, switching from using chloride to using chloramine as residual drinking water disinfectant. However, no change in water disinfection type was made by the Chicago department during the period of interest. Findings suggested that water disinfection type was not an important risk factor in this outbreak. And next hypothesis, poor contact lens hygiene is widely recognized as a risk factor for Acanthamoeba keratitis. Over 80% of cases of Acanthamoeba keratitis could be prevented by the adequate use of effective disinfection system. And increased emphasis on the importance of maintaining good hygiene with soft, conventional, and reused disposable lenses, using hydrogen peroxide or other disinfection system that are effective against Acanthamoeba could almost eliminate the severe cause of keratitis. So let's look over difficulties during this investigation. First, a small sample size. Initially, we had 221 Acanthamoeba keratitis patients identified from 37 states, and we had 105 case patients, further losing patients due to unable to match. And in the end, we had 91 case patients with match controls. Separate analyses were performed among users of rigid contact lenses and non-contact lenses users. However, the sample size were small as well, and no associations were found. Also, since it was an interview method during this case control study, recall bias and misclassification bias might be introduced. Acanthamoeba keratitis diagnostic specific but insensitive. So preferred diagnostic methods varied by centers, and inclusion of only patients with culture confirmed cases may have introduced regional testing bias and underestimated the scope of outbreak. So AMOCMP lots were not identical when we received the samples, and because of the incomplete case reporting and enrollment in case control study, incident rates were not calculated. Let's take a look at this outbreak consequences. So we had 32 patients with resolved pharmacologic therapy. 29 patients were undergoing pharmacologic therapy during the outbreak investigation. And 21 received the corneal transplant, and 3 were waiting for corneal transplant. So the most severe consequence of Acanthamoeba keratitis is blindness. In refer to image 4, this is how eye infection look from Acanthamoeba, this picture taken from CDC. In my last slide, I would like to discuss changes that FDA has made after this outbreak. So, although there are strict regulations on lenses care products were developed in 1990s in Europe and United States, FDA guidelines were the most extensive. However, it did not include Acanthamoeba as a challenge organism. After this outbreak, ophthalmic device panel of the FDA Medical Devices Advisory Committee has recommended adding Acanthamoeba as a challenge organism for testing of contact lens solutions. And last 2 slides are my references. Thank you very much for your attention.